Welcome to the HITea with Grace podcast, where we spill the tea on HIT. Today, I'm honored to welcome Bevey Miner, EVP of Healthcare Strategy for Consensus Cloud Solutions, to the pod. We've run in the same circles for quite some time now, so I'm thrilled we have the opportunity to learn from her today.
Thank you.
So let's start by having you share the career path that brought you to your role at Consensus Cloud Solutions.
That's an interesting story, Grace. I was a journalist out of undergrad reporting the news, and I worked for the Arizona Republic for about 5 years. But the twists and turns took me into a focus on healthcare. And I've been in health information technology for about 20 years, and people that have been always say we started at 10. So that's a common giggle amongst us, but I have been in the business for a long time and seen a lot of changes and not enough changes.
Wow. So let's dive into chatting HIT. Tell us a little bit about the state of the industry's push to implement TEFCA and FHIR, that's FHIR standards. Can you give our listeners a little background on TEFCA and FHIR, and then talk a bit about how these efforts are going and what gaps have yet to be filled?
Yeah, I love that question. Grace, if you look at why we have not achieved interoperability in healthcare, I've been trying to push for it. My colleagues have, the industry has, for well over 20 years. And one of the reasons is we don't have a data sharing standard. When you look at other industries, in the banking industry, there's a data standard for sharing data. The same thing in the airline industry, et cetera. In healthcare, we have not really focused on one single way that you communicate. So it's the Tower of Babel. It's like languages that don't talk to each other. It's communication that needs translation. And it has become very complicated, slowed down the way data is absorbed at the receiving end and how it becomes actionable. So we know we need to get to a standard of actually sharing data. HL7's been around for a long time. That's been the basic way we've shared structured data. X12 is a format called EDI, and X12 is used across the board. It's probably the most common way of sharing data. We're moving to this FHIR construct underneath what's called TEFCA. Now, people get confused because they think TEFCA and FHIR are like two competing kinds of standards of sharing data. The way the federal government released this recently is to have a common agreement that's more like a legal agreement, if you could think of it that way, that has a commitment that you will share your data in the healthcare industry using this kind of a framework. You're going to share that data in a FHIR-based standard. So the FHIR is the actual technology. TEFCA is the common framework and the agreement. And we're pushing hard to get to that. Why? The reason is because when you share data in that FHIR methodology, the data becomes structured, right? And so what do I mean by structured data? When you think of a picture and you think of a fax and you think of an image and you think of something scanned, it's a picture. And as a picture, somebody has to read it to do anything with it. You have to read who's the patient that's on this lab result. What's the patient's name? What's their demographics? Because I have to go find their chart. And then I have to take that lab result and I have to manually attach it to the chart. That data entry is slowing down treatment. It's bogging down our workflows. And it's really adding to a lot of workforce stress because no nurse got into this business to do a lot of data entry. It can't read any of the clinical content. It can't read what that lab result is, the lab values. It can't read any of the other important information that the diagnosis is, et cetera, or even the treatments. If it's a referral, it can't even read the document type. Can't even read it as a lab. If it's a referral, it's really important that get read quickly because referrals to specialist or post-acute that's the lifeblood. They have to accept those referrals and keep that continuity of care moving forward. So the way FHIR works is it takes that picture and it turns it into these very separate data fields. As an example, if it starts already as structured, meaning that you already have data fields that are completely separate, that can match to a receiving end fields, then you can send it as a FHIR message and it keeps the integrity of the construction. You have to have some way of pulling that data out and turning it into these separate fields in order for it to become FHIR enabled. So when you think about the healthcare industry and all the physicians are using electronic health records, their heads are down into computers all the time. Anything they type, all of the clinical information has a place. It can be pulled out of the electronic health record and sent to another electronic health record that matches to that same kind of certified types of standards. In the case of what we call unstructured document, like a lockdown PDF document, you have to get the data out. So companies are working towards using natural language processing, reading all the characters. Once you have the data that's extracted, you can measure it. Your large language models can add it to large analytics and computations. You can say, give me all my referrals for patients at the age of 65 that happen to have 2 comorbidities. And now you have structured data that you can do something with. Companies like ours put NLP on top of this unstructured data. Now we can extrapolate it. We can turn it into various different structured fields. JSON is the way to do that. And then you can map it to the receiving end. Specifically in the other EHR, that's the receiving. Interoperability is a receiving problem. In almost any instance, you have somebody talking, that's coming out. It's a receiving problem. So we have to make that receiving side easy, digestible, and not add to that workflow. So when it's mapped to the receiving side, then it ends up in the electronic health record, and you've got the lab result right there in the patient's chart. The provider can act on it, and we can have treatment move. It expedites treatment. And it also removes the errors that happen when you end up with data entry. And now that you've got that on top, you can use generative AI to actually do a whole bunch of different things, because now that document can be used as a part of any kind of analytics or prompt questions or anything like that. Seems perfect, right?
Let's just do it. Industry?
Come on, let's everybody get on that bandwagon, right? Back under Obamacare, a couple decades ago, the federal government released meaningful use money, as we call it. And the reason I'm keeping this very simple is because I do recognize your audience is the sophisticated people in healthcare. They may be going, yeah, I know all this. So when we did meaningful use and we gave money to physicians to purchase an electronic health record, we gave them money, and they weren't moving to electronic health records before. So they bought an electronic health record. And then we added these quality metrics and incentives built into the electronic health record that said, if you use this meaningfully. I was working for a company called Allscripts. We were very instrumental in creating what meaningful use was. How do you use something meaningfully? And the electronic health record can keep track of that. It can keep track of, have you put all of your diabetes patients on a nutrition plan? If you have somebody, a patient that admitted that they smoke, are they on a smoking cessation program? It's these different quality metrics, and then you get paid more money if you meet those quality metrics for your claims to Medicare and Medicaid. And if you don't, you will have money taken away from you. That's really the foundation of value-based care today. It's not, let's don't pay you when the providers, when the patients are sick, they're incentivized to keep you sick. Let's pay when you've done something that's meaningful in terms of the quality of delivery of care. We left out 2 decades ago, CMS doling out all this money under accountable care, left out certain providers. They left out behavioral health. They left out the behavioral therapist. They left out the substance abuse clinics. They left out a lot of post-acute, skilled nursing facilities, all left out of getting the money to be able to move to these certified electronic health records. So fast forward today, these are nonprofit organizations that treat some of our most vulnerable patients in our most challenging neighborhoods. And they don't have these certified electronic health records. They haven't invested in them because it requires a pretty substantial investment in technology, as well as technology understanding, technology skill set, how to implement it and how to maintain it and how to get to the next certified levels. Anybody that's using electronic health record or any hospital system that has to go to the next level of Epic or the next level of Cerner will tell you it's expensive, it's complicated. So let's talk about when a patient's discharged from the hospital as an example. So we have a patient discharged from the hospital, and they were admitted in emergency for some behavioral health incidents, and maybe some other comorbid issues. And then they were discharged from the hospital, and they're an underserved patient. They're being discharged into a neighborhood where their providers don't really have certified electronic health records. And even more specifically, the behavioral health center that they're being discharged to does not have a certified electronic health record. So how are you going to communicate to that?
You're missing so much information if you're not able to communicate and have those receivers having some type of information sharing between these critical pieces of your care. And it really does affect, it seems like, the most desperate of us all. And so that's really sad as well. So let's talk about interoperability in this kind of post-acute space. What is the impact of CMS interoperability and prior authorization rules for provider quality measures and basically on post-acute care providers? Is that fueling some of the work to be done to help improve interoperability?
Yeah. If we focus and drill down on that, you're spot on in that it's our most vulnerable patient populations in some instances, or it's our aging patient population that leaves the hospital, goes to the skilled nursing facility. More so, what we're doing is we are discharging patients at much higher levels of acuity, of higher levels of sickness, and they're going home to be treated at home health. What does home health use? Some of them are still on 3-ring binders and paper. Oh, log in here what treatment you gave to the patient in their home. What medications were delivered is on tab 3. Is that we have to get to a point where we have created tech equity in this system in order to really say that we're doing something for health equity. We've often thought that health equity was that we just have to treat patients the exact same, no matter where they live, no matter what their demographics or their background are, they need to be treated exactly the same. And health equity cannot be equal unless you have tech equity, because the way we're looking at technology and investments is that it is going to make the treatment of care more knowledgeable. You're going to have more information at your fingertips. Take that away from somebody that is trying to treat a vulnerable patient, and they're not going to be treated the exact same way. The other piece I wanted to mention, which is interesting, is the whole craze of Gen AI, generative AI. We can do predictive models. We can do population health. We've got public health is moving to data modernization so that we can do more surveillances the right way. When Gen AI has to crunch through a lot of content and data, and I brought this up before, you cannot include what can't be separated and measured. It's naturally going to have a bias. It's already going to miss the data coming from those systems and those care settings that cannot submit structured content into the analysis or even public health databases. So that brings us to, what do we do about it? What do we do? And I'll talk about the prior authorization piece in a minute. Of course, it's getting so much attention right now. We've got to figure out a way to fund the have-nots.
So true.
And there's conversations about, well, the haves need to fund the have-nots. The large hospital systems need to fund equitable technology in all of their training partners in their communities so everyone can communicate the same way. And I know there's some discussions and models, and in some communities, that's exactly what's happening. The large academic medical center is bringing on these providers, and they're giving them the kind of technology and tools that they need. I have advocated that we need to look at this as a federal funding initiative. We need to figure out how can we create that level of equitable way that we share data. If it's Medicaid, you can use, a lot of the waivers are going to be available for increasing technology. And then we create rules within the federal government that are just broad sweeping rules that say, okay, you have to approve payers, you have to approve an urgent prior authorization for Medicare Advantage patients within 72 hours, which is the prior authorization rule that was passed not too long ago. The payers look like they're on the hot seat for this because we know the prior authorization problem, magnified even recently, is weeks. It can be months. It can be, the docs have to send in another authorization. They're on the phone calling. In a post-acute environment, you've got case managers that are trying to get a patient into a skilled nursing facility bed, but they have to get a prior authorization that is warranted and that the payer is going to approve them spending a week, 2 weeks, whatever it is, in a skilled nursing facility before the patient is delivered at the front door of that skilled nursing facility.
Out of control.
What are you supposed to do with the patient? We hear stories over and over again. Patients still sitting in the hospital. A much more expensive bed in that hospital than in that skilled nursing facility, but they haven't been approved to move. The payers want the kind of structured data that CMS is saying the providers have to send a prior authorization in. They have to do it in a structured manner. Now we're the largest digital cloud faxing company. We can look inside our faxes, our billions of faxes, and we can see just how many are prior authorizations and are they handwritten. Physicians will print out the prior authorization if they don't have that structured way of doing it. They will fill it out by hand, and then they will send it in to the payer for authorization. And the case managers at a hospital that are trying to discharge patients are making phone calls. So the industry has to come together. We have to support the APIs and the structured data content that says send a prior authorization in this FHIR X12 format. It goes to the payers. Now it's structured data, and now the payers can do something about it without someone having to look at the prior authorization, having to make a human decision. Prior authorizations were introduced with good intent. The intent was that the payers could help determine whether that's the right path of care, consult and work in partnership with the provider to say, rather than just throwing the patient through something really invasive like surgery, because that's what you want to do, and under fee-based models, they're going to go right for surgery, the health plan can say, let's think about this in steps. Has the patient gone through physical therapy? Is there some other way that we can create a better path of care without harming and damaging the patient by delaying care? And that was the intent. There are some payers that have hundreds and hundreds of people looking at prior authorizations, trying to get through them. And the natural course that the payers took was, let's deny most of them, and half the time the patient won't even, and I didn't say most of them, that's a universal statement, but an alarming percentage, because the patients won't argue, the physicians won't come back, and we didn't have to pay for the care. But in the long run, the circle comes back and forth, and in many instances, the patient ends up in exacerbating situations because they didn't get the care that they needed. I'm a patient. All of your listeners and your viewers, we're all patients. And whether you have experienced that same problem of not being able to get the kind of care you want and do it expeditiously because of that same authorization process, or a loved one has, how frustrating that is. So all this movement towards what we're trying to do to expedite prior authorizations, especially what CMS is doing, is centered on making the data easier to read, making it digestible, and making those decisions more equitable, making them faster, and not universally just throwing something like Gen AI to say deny everything and then hope nobody cares. And so I think we're going to see some things next year as we start getting ready for the implementation of this rule, which will not happen until January 1st of 2027. And a lot of people go, we need solutions now. It's hard and it's daunting for systems to completely re-engineer a workflow. What CMS did after a lot of comment letters and discussion under a proposed rule is they pushed the date to go live for this back by a year. But in 2025 and 2026, the systems, the providers, the health insurers, any intermediaries between communicating with post-acute are all supposed to get themselves ready to be able to support this new standard and to be able to support the way that we need to share data. This was passed into a rule as part of the 21st Century Cures Act, which inside that law, there's a difference between rules and laws. Laws usually create the umbrella. The rules underneath talk about how you're going to adhere to those laws. The 21st Century Cures Act, bipartisan law passed in 2016, and this prior authorization rule that was recently submitted was, of course, done in this administration. So things can change. We don't know where it's really going to go under the next administration. I don't think it'll go backwards because we know there's a big focus on what's happening with the prior authorization problem and the continuity of care. But we may see some interesting acceleration. We may see some additional comments about how to implement this rule and other rules that are coming down. So it'll be an interesting year of watching how policy can shape execution in healthcare next year. And I, for one, am pretty excited about being right in the middle of how things always change and advocating for, most recently, making sure that tech equity and health equity are looked at as an equal package for our healthcare system into inequality of how patients are treated and data is shared.
I love to hear that. And I'm so grateful that you are at the forefront of trying to just lead the charge on that, because it's like the quintuple aim, right? They've added equity as part of that. So I'm wondering, you hear a lot about QHINs in the industry. How are post-acute providers and others impacted positively or negatively with what QHINs are in the industry?
Yeah, QHINs, the concept of a QHIN, and since I've been in this business for quite a while, the concept of a QHIN and how we share community data has been around for so long. When I first entered the health information exchange kind of industry, we called them RIOs, which were regional health information organizations. Because if you think of healthcare, it's very community. Data is mostly shared amongst that, small community. We put inside the electronic health record under some certification processes, the ability to query patients. That's been in there. If you use a certified electronic health record, you can use Carry Quality to query for what happened to where was a particular patient. And it inched the industry forward a little bit. What we've realized is that it's not working. It's really not working because participation in the Carry Quality Network or the Commonwealth Network just wasn't universal. So it's kind of like you go out to your email and you're trying to find information, but there isn't anything that was digitally provided. It just ends up at a complete roadblock. Many times it was patients not found. I can't find any information. Mrs. Smith, you're sitting here right in my exam room saying you left the hospital yesterday. We can't find anything. What happens? You have to call the hospital, say, was Mrs. Smith in your hospital? Oh, can you send us her discharge summary? Can you send us the information of what happened to her? Because Mrs. Smith happens to be 70 years old and she has no clue what happened to her and why she was even in the emergency room and what was the diagnosis or the care plan that was supposed to follow. Modeled after a lot of the cell tower kind of a concept, if you think about that, is the QHINs are now being set up to be queryable data. We have all these little QHINs, so a QHIN can ping another QHIN. It's a network of QHINs is essentially what is being built in this country today. It was obvious that the EHR vendors became a QHIN because you're inside your EHR and you want to query Epic hospitals, you want to query Epic providers to send you information on a particular patient. That's going to be a huge universe of being able to query, but it's not everybody. It's not including the Athena, the NextGen, the eClinicalWorks, the Cerner hospital system. So you're leaving out some. It also is not going to query something like all of your medications that you've been on. Run by SureScripts today, they have a wealth of information about what active meds you're on, what meds have you picked up. SureScripts is going to be a QHIN right after the first of the year. And some of these regional health information organizations, they're not regional today. They're really called health information exchanges. They have also put their hat in the ring to be a QHIN because they already share a lot of. I don't think we've still picked up the universe of query just yet because there's still pockets. The VA isn't on Epic. The VA has to have data queried all the time. You're sitting in a non-vet hospital, and they were in the Veterans Hospital just a month ago. So we have to create a network of query to query. Not everybody has to be on Verizon or T-Mobile or AT&T. The towers all kind of query and talk to each other. But who does that leave out? Those that don't have a certified EHR so that they can go, hey, I want to find everything on Mrs. Smith because she showed up at my community clinic and she says she was admitted to the hospital a week ago, and that she's been a mental health patient and has had treatment at a psych hospital. And I can't find any information on Mrs. Smith, but how am I supposed to? The QHINs are operating inside an already existing workflow. It's not like you go to a separate portal and you query all the QHINs. They are embedded in, for the most part, electronic health records. Now, a skilled nursing facility can do a query if they have the capability, like a point-click care software that can do it. Home health could do it, but if you're on a 3-ring binder, how are you supposed to call the QHIN? I'm trying to call the QHIN and find out if Mrs. Smith, where she was like 3 months ago. You don't have the technology to do it. So it's a really great way for us to be moving to find information on patients, especially when there's gaps in that data, but it's still not equitable. And I think a lot of people don't invite me to meetings sometimes because they're like, I just got back from an annual meeting of policy.
TP, is that?
ASTP, Assistant Secretary for Technology and Policy, which used to be Office of National Coordinator. They are the technology nucleus for Health and Human Services. They have an annual meeting. I just got back from the annual meeting. And everything had two themes. It was really AI and TEFCA. And as I have these hall conversations, I'm like, what are you going to do for those that can't get access to a QHIN and can't support TEFCA because they don't have the funds to be able to do it? I was listening to a panel where a representative from community clinics and community hospitals, critical access hospitals, was talking about AI. And she parroted exactly what I just said, that what are we supposed to do? We can't participate in some of the models that you've thrown at us, and how are we going to fund it? I think we have to wait for success, and we have to wait for the QHINs to get up and running, and then what it does, it magnifies the have-nots.
True.
The pain that physicians the haves will start to say, yeah, but I'm trying to query on Mrs. Smith, and she was at a psych hospital, or she's been in and out of behavioral health treatments and substance abuse clinics. And with the behavioral health is growing as a concern and a clinical challenge in America. Many people are in substance abuse clinics and treatments and things like that. And they're on antidepressants, et cetera. You can mess up their whole constitution by putting them on a whole bunch of sleeping pills at the same time. And it's duplicate therapy stuff. We need to know, what medications are you taking? Thank you, Surscripts, especially now that a lot of those medications under behavioral health can be shared. We need to know, where have you been? Where have you been seen? I think that's going to start to get magnified more and more, especially, like I said, as the haves are trying to think that the TEFCA and the QHIN system is going to be a universal solution. It will be a huge solution. I don't want to be uninvited to meetings anymore because people are like, well, we don't have an answer for this. I was listening to the Office of Minority Health, somebody from the Office of Minority Health that operates in our federal government focus, and they were talking about data modernization and collecting the right kind of demographics in a structured data format. And I asked a public question at the microphone. Well, what are you going to do about those underserved? You are in the Office of Minority Health. What are you going to do about those minority clinics, the clinics that are serving this population that are still so much either on paper or unstructured documents? And she really just looked at me in the audience and said, I don't have an answer for that. So I'm hopeful that next year we will start to have answers for that. And I encourage your listeners, if they can, to adopt these new standards. If they feel they've got a lot of unstructured data, how am I supposed to adopt these standards? I'm supposed to send it all in some sort of structured format. And yet, even if I use an electronic health record, there is a plethora of images and faxes and scanned images sitting inside a patient's electronic health record. To really understand that there's technologies today that can extrapolate that and turn it into the kind of structured data that the receiving ends need. But we have to go as the industry. I hope we're not going to drag our feet, and we have to let it play out. And I hope it really provides some focus on some of those underserved areas that need to have better technology.
Absolutely. So inspiring. And I think our listeners are there with you. I think we all see how the healthcare industry is hurting the underserved and the vulnerable populations, rural hospitals, folks that just have typical access to care in general, and then interoperability being such a critical piece to making sure we have more equitable care overall. So I appreciate you being an advocate for that. We're cheering you on, Bevey. I know our listeners love learning from you and love hearing about the current state and future of interoperability. But we also want to learn more about you as a leader. Tell me, Bevey, you're a busy working woman with a big mission and a big job. How do you work your best and make a difference? What are habits that you have and hobbies you have that just keep you going so that you can be your best when you're working?
It's interesting because so many people say the challenge we all have with work-life balance is that we become our jobs. We get seeped into our jobs, define our archetype, our makeup of our jobs. And when your job is filled with so much passion and your job is filled with an altruistic thing that you want to do and your job is filled with a personal story, it doesn't become your job. One of my most probably fulfilling and proud moments in working in healthcare technology was when I was hired at Allscripts, first hired at Allscripts, and the company had a standalone prescribing product, electronic prescribing product, and nobody was using it. This is well before meaningful use, well before the federal government put any funding into modernizing or moving off of paper files, for that matter. And the physicians had their script pads. They just pulled it out of their lab coat. They'd write 3 prescriptions, hand it to you, and then you'd lose the prescription. If you're a busy mom, it would be in the diaper bag someplace, and it was always a challenge because you had to go to the pharmacy to pick it up, then you had to wait for it. And we knew that we could create, by putting the trading partners together, a way to do electronic prescribing that would have the prescription already sitting there at the pharmacy. But nobody was going to buy this thing. So we decided to give it away for free because we realized that we have to get docs off at least one paper workflow. When I was hired to work on this project, my father almost died because he had 3 chronic illnesses. And in a given day, he could be on anywhere between 10 to 12 medications.
I'm so sorry.
His geriatric internist would prescribe him something. His neurologist would prescribe him something. Somebody else would prescribe him something. And he ended up on 4 duplicate mood-altering medications. They were duplicate therapies. And we ended up finding him on the bathroom floor in convulsions and everything else.
Heartbreaking.
Horrible. So I watched my dad have to get admitted to a hospital, get taken off all of his medications, and like a heroin addict for 6 days, go through withdrawals for all of the meds that he had been put on. When I asked the physician, why are you not using this free, it was called NEPSI, National E-Prescribing Patient Safety Initiative, which is what we introduced, free of charge to the physicians. The physicians at that time were saying, the pharmacists can see if there's a contraindication of medications. We created the program. We launched it as free. And I worked with governors of states to try and get it mandated. We worked with the federal government to try and figure out how we can incentivize physicians to move to this electronic health record system.
Yeah. How do you separate work from life when you literally saw your work in front of your face as your dad dying and suffering? Yeah.
So appreciative that Allscripts gave me the opportunity to change that system. And we did. We got 150,000 physicians up and running on electronic prescribing. The company was making money off of working with the health plans to be able to show whether the drugs were on formulary. So think about this too. You got a prescription, you went to the pharmacy to pick it up, and all of a sudden it's going to cost $100. And you go, I'm not going to pay for that. Tell my doctor I want something else. So inside the electronic health record, when we worked with our health plans, we could look at what the patient was eligible for and see what was a brand, what was generic, and make sure that the amount they were going to have to pay was at least disclosed while the patient was still sitting in the exam room at point of care. So that was a great model for compliance for physicians or patients to take their medications. And the system really made a difference. I don't even know where paper prescriptions are done. We had to work really
now. E-prescribing is that is what happens, except maybe in specialty pharmacy, which I think there's still a lot of disruption to be had there in that specialty medication space. But other than that, everyone else is doing it.
When we were working in lobbying in DC, we got special incentives. If you did 50% of your medications electronically, you got more reimbursement. But we could not get the government to move to electronic prescribing for controlled substances.
Oh my goodness.
They said, no, it still has to be paper. Triplicate in some states. It has to be paper. You have to go to the pharmacy and it has to be paper. We were like, federal government, don't you have covert and really important things in the Justice Department going over the internet? They thought it was going to be more of a way fraud could get in for substance prescriptions and Schedule IIs. We have caught more people violating substance abuse and prescriptions under Schedule II drugs in an electronic world than we ever would have been able to do in a paper-based.
Wow.
That took a while to get that to happen, but now all prescriptions can go electronically. The same story, it drives my passion for prior authorizations.
Mm-hmm.
not only because it's a pain and I myself have had to wait for authorizations to get MRIs and things like that, but I have a family member who had symptoms of what potentially could have been soft tissue cancer, but was not authorized to go see an oncologist or even an orthopedic surgeon, but was sent back for PT and PT and PT and PT. By the time he finally got into an orthopedic surgeon, it took forever to get the MRI done. Once that happened, the orthopedic surgeon said, I need to get you over to oncology right away.
Oh, man.
By the time he got to oncology, he was in stage 4 sarcoma.
I'm so sorry.
It was, now, can I say that the authorization process and how broken it was led to his death? Ultimately, sarcomas are hard to detect. It's hard to diagnose. It certainly isn't an easy one, but quick diagnosis on it means you can do other things. So I'm passionate about changing that prior authorization process too. And usually when that happens, and I've got a personal story.
Thank you so much for sharing those stories with us. And I know they're deeply personal and it probably brings up a lot for you just personally, but it does help us understand where you're coming from and what's driving you to make these changes in healthcare. If thinking back to your younger self, coming into health IT space, do you have any advice you would give your younger self about making that transition and leap into health IT? And what would that advice be? Or any leadership advice that you would give to your younger self?
Yeah, I think when people get into technology, they fail to talk about the implications of what that technology will do on the back end. Are you working for a cybersecurity company? What does that really mean? What does your job answering the phones do at the end of the day? What does your product really do? And even at our company, we're well over 500 people. I always want to make sure that as you come into work and every day, you don't think of yourself as a transactional faxes sent and received, that we think about how we're making business processes easier, that we're making healthcare safer, that we're doing it for the financial industry. We're doing it for manufacturing. We're really helping our workforce. Whatever it may be, try to think about, if you're in technology, try to think about whatever job you have, the impact that will have at the end of the day. What is your product really supposed to be doing? Otherwise, a job is just a job. And it's really hard for young people today because back when I was starting look, I was a journalist. How did I end up here? That's what a lot of people say, right? They're like, you were a journalist and now you're in healthcare technology and working on strategy and policy. We could jump around. But today, because the way we even educate people, it can be on such a specific way that you graduate with a skill set. And you almost have to choose that swim lane. And you have to deliberately choose that swim lane. If you decide, I want to go into marketing and I want to work in a healthcare company and I want to do the marketing side of a healthcare company. You can't just say, I just want to go into marketing. You have to say, do I want to do SEO and SEM in marketing? Do I want to do demand generation programs? Do I want to do event management in marketing? Used to be, you could just be a generalist and you could say, yeah, I just want to go into marketing at a healthcare company. So think about deliberately, how do you see your job in 5 years? What's a day in the life of your job in 5 years? What's your career path? Where do you think it could grow? And if it's marketing and you're choosing marketing, you're going to stay in marketing for a while. Now, it doesn't mean that companies don't offer you an opportunity to zigzag here, there, and there. But if you go to sales because you're showing that you really understand the customer base. But do you like sales? Day in the life of your job, 5 years from now. Do you like working with people? Do you like having a specific goal that you have to achieve? Did I make my number? Did I not make my number? Do I want to get paid on how much I work and close business? And there are some people that are so driven by the competitive nature of a sales. Mm-hmm. And then there's some kids that go, well, I don't know what I want to do. I'm just going to go into a sales job. And they go, oh, I hate it. The pressure is so bad. And it's every day. And how many customers did you call? And they don't have the constitution to be able to really do that. So to the extent that you can, think about what you really want to try and do and look at all of your different options. Day in the life, five years from now. I did this with my kids. My son wanted to be a fireman or FBI agent or something like that. And I say, explain a day in the life of your job 5 years from now.
Such great advice.
How are you driving? Yeah. I mean, if you want to be an FBI agent, or are you coming home for dinner every night? To your wife, to your kids? If you don't care, you don't want an 8-to-5 job, find something else that's like that. Some people say, I could never do a desk job. I don't day in the life 5 years from now and I have to sit at a desk, deal with corporate America. Yeah. But yeah, I've mentored a lot of young people and said, if you can, think about a day in the life of your job 5 years from now. Better yet, go shadow somebody.
Brilliant.
That is in that same position that you could be in 5 years from now. And see what a day in the life of their job is. And that's what you will end up with if you keep on that career path. And it's really eye-opening. And it gets them more passionate, or it goes, yeah, no, I don't think I want to do that.
And I love this idea of really specializing, getting yourself specialized and making sure that it's the work-life balance that you want. And it's giving you what you need to feel mission-driven or purposeful. And just really thinking through all of those questions. I don't think people do that enough. And it's really critical to just happiness in life, let alone happiness in career. To finish this conversation off, where can our listeners find you online?
You can always reach me at bevey.miner at consensus.com. I'm also on LinkedIn. It's Bevey Miner on X. I always love giving ideas to help mentor kids and get them on the right career path. We need young, new, skilled talent, particularly to look at things like healthcare. If you ever want to say, I want to do that AI thing, that seems fun and it looks like there's a lot of opportunity. The day in the life of AI 5 years from now, who knows? But you have so many different paths and choices you could take. And look, I did it with my kids. My son wanted to be a craniofacial specialist. I had him work with the Interface group here in San Diego and go look at what it is to give cleft palate surgery down in Mexicali to see if he could stomach it even when an operator. Those are the kind of things I think you need to think about. And then it doesn't become a job. It either becomes a career path that you're really motivated to try and achieve, or it's something that you're passionate about. And always think about work-life balance if you care about that. Some people say, I just want to immerse myself in a job. I'm not looking to get married and have a family anytime soon.
That's terrific. Before I forget, did you happen to bring tea?
I did.
Tell me about
I don't know if your viewers can see that, but this cup has dream all over it, written in different kind of fonts, written phonetically, and it sums up really how I think about my job. I think about my job as dream it. Dream what you want to do in 5 years from now. And if that dream turns out to be, hey, that's not where I really think I want to go, then change it. But dream about it, visualize it, go experience it, talk to people, ask mentors, and never stop trying to fulfill your dreams, which seems like a little trite, but it's very true. And a lot of people don't understand how to even execute that.
Well, thank you so much for joining us today. Really appreciated learning from you.
I hope your listeners got some valuable information off of this.
Check out the HITea with Grace podcast for more interviews with great guests like Bevey today. Cheers.
Like a Girl Media is more than a media network. It's a community. We want to meet you and amplify your voice and the voices of outstanding women innovating in healthcare. Interested in starting your own podcast or hosting an event near you? Connect with us online or in person. We're here to support and empower you.